Hi, everybody. I always forget when we give them our bio that they're gonna have to read it, and it's gonna be like 45 minutes of the presentation. So next time I will give you 2 sentences. Don't worry. So you know who I am. I am gonna do the first half of the presentation, which is going to be on a little bit of an introduction to applied behavior analysis, and we're also going to talk about some behavior analytic strategies for improving quality of sleep. And then the second half of the presentation is going to be given by Dr. Annette Griffith, who's right here. She is my boss. She was my dissertation supervisor and my academic advisor, and she knows a whole lot of stuff. So she'll be doing the second half of the presentation. So I just wanted to start with a little bit of an introduction to applied behavior analysis. So I'm assuming that if you're here, you probably have a little bit of a guess what applied behavior analysis is as you're at an ABA presentation. But behavior analysis is essentially the science to understanding why behavior occurs and how we change behavior. So we're interested in learning about how people learn. We're interested in learning about what types of environmental variables are maintaining a specific behavior. And when we understand that, we can learn how to change those behaviors. And there's kind of 2, not really branches of behavior analysis, but there's 2 different focuses. So there's behavior analysis, which is interested in looking at the laws of behavior and essentially any behavior. But applied behavior analysis is really focused on behaviors that are socially significant. So I'm interested in looking at something that's going to improve your quality of life and not just doing things for the sake of doing them. And ABA practitioners should be working collaboratively with everybody else that you're working with. So I think there's sometimes a little bit of a misconception that ABA is meant to be provided just by itself, but ABA can work collaboratively with all of your other services. So your speech therapist, your occupational therapist, your people at school. If you are, like for example, I've supported many adults with PWS and we work with their psychiatrist. So helping to make sure all these services are tied together and delivered in a cohesive way that's going to best support your child. Yeah. Yeah, so just for the purposes of the presentation, you can ask me questions whenever you want, but they did ask me to repeat them because they can't hear you. So your question was, in your state, they will not put your child in ABA therapy unless they have a diagnosis of autism. That is very common. So for the only current diagnosis that ABA is recognized as by insurance for as a therapy is for autism. There are some states like Wisconsin where anybody with a developmental disability can apply and can get ABA services, but that's not the case in most states. So there are things that you can do on your own, and there's also, you can get some behavior analytics services at school if you can't get it through your insurance company. So for example, if any of you is interested, I have a free parent training program that I run on a 14-week cycle that will teach you all the basics that you need to know about applied behavior analysis so that you can support your child. Of course, it's not as extensive as if you had insurance to fund it, but it gives you the basics of what you need to know. And then if you are experiencing behavior challenges in school, we can request an FBA and a behavior plan at school so that you can have the support in both areas, if that makes sense. But yeah, that's a great question. So I'm going to start out by talking a little bit about some strategies to improve sleep. So sleep challenges, as I'm sure many of you know, are a major challenge for people with PWS. Some of these difficulties include sleep apnea, nighttime awakenings and insomnia, so waking up in the middle of the night, staying up. Waking up really early is one complaint that I hear from parents a lot. So my kid goes to bed at 7, but then they wake up at 4 o'clock in the morning. And less frequently we'll have bedtime refusal. So most kids with PWS are really sleepy by the time it gets to bedtime, and so you won't have some issues with that. But for some of our, the children that I've worked with who have a lot of rigidity around that bedtime routine, sometimes you can get some challenging behaviors and some refusals, which will delay bedtime. And then of course, narcolepsy and daytime sleepiness. So that's a major challenge. Of course, if you're not sleeping at night, you're not going to feel so good in the daytime. But if you have an additional challenge like excessive daytime sleepiness on top of that or narcolepsy, that can further complicate things. And so we have disruptions in both the sleep quantity, so the amount of sleep that we want the person to get, and we also have disruptions in the sleep quality. So even though you're sleeping, maybe you're not getting as deep and restful a sleep as we would hope. And of course, this increases stress for everybody. So if your child is not sleeping, you're not sleeping, sometimes they're getting up and doing disruptive things in the middle of the night, which means their siblings aren't sleeping. I worked with one child who really liked to get up and flip the lights on and off, which is not such a good thing when it's 3 o'clock in the morning. And then, of course, it can also result in an increase in behavior problems. So if you're really tired and you have to go to school and they're making you do a lot of really difficult things, that's going to increase not just your child with PWS's behavior challenges, but if you do that to me, I'm going to have behavior problems. So, and then just reduced daytime functioning. So inability to concentrate, difficulty getting things done are all a result of sleep disturbances associated with PWS. And so I guess the first question when we're talking about ABA and sleep is, what do we already know about the types of interventions that could be effective for people with PWS? And the answer is we don't know a whole lot. So existing, hi.
Is Esther Levi in here?
Esther Levi?
Okay.
Nope, sorry. Don't have her, Stacy, don't know what to tell you. So we know very little about behavior analytic strategies that can be helpful for people with PWS. So I had one master's student recently who took an intervention that's been very effective for children with autism and tried to replicate those results with people with PWS. And what we found, unsurprisingly, is that people with PWS have much different challenges than children with autism do. So for children with autism, oftentimes it's a lot more bedtime resistance. And with people with PWS, it's most often that they wake up in the middle of the night and they will not go back to sleep, or they wake up at 4 o'clock in the morning and they are ready to go and they have all their loud toys out and they're doing all kinds of fun things. So it's a little bit different. However, we do have some strategies that have been effective for children with autism that I think we can take and apply to children with PWS. And also some of these strategies have been applied to neurotypical kids who just have sleep-related challenges or had a hard time when they were younger learning to sleep independently, and also for other people with developmental disabilities of different types who also struggle with sleep. So we're going to talk a little bit about those today. So within behavior analysis, we have something called a medical rule-out, and I think the longer I work with PWS, the more important I think that is, because a lot of times things that we perceive to be behavioral at the end of the day turn out to have some type of underlying medical reason. So whenever we think about putting some behavior analytic strategies in place, we want to first make sure that we're ruling out anything medical. And with PWS, we know that there can be so many medical complications associated with sleep that it's important to check that first. So you would need to, I am not a sleep doctor, and I am not Dr. Miller, who knows everything about everything. So you would need to consult with your physician and find out if you need to get a rule out for something like sleep apnea, or find out if there's anything else that could potentially be going on. If your physician clears you and says, nope, I think we're doing the best that we can with the resources that we have, go ahead and try some behavioral strategies, then you would be in the clear to go ahead and try something. So when we start any type of behavior analytic intervention, the first thing that we want to do is to figure out what the problem is. So I would want to first collect some data. Any of you who's heard me talk or worked with me know I will always want you to collect data. But what we're really looking for is identifying patterns. So when you're exhausted, when your child's not sleeping, you may not have a good picture of exactly what the pattern is. Is it that they're going to bed early some days and that's resulting in them waking up too early the next day? Is it that they're napping for an excessively long time in the daytime and that's resulting in nighttime awakenings? Is it that they're mid-potty training, they have to wake up and go to the bathroom in the middle of the night, and that's resulting in them staying awake for an extended period of time? So we really want to know what's going on before we try to put anything in place. So the way that you can just get a picture of what's going on is do something like a sleep diary. You can make that as simple or as complicated as you would like to make it. You can take a notebook and you can say, let me write down what time you went to bed, what time you woke up in the middle of the night, how long you stayed awake for, what time you went back to sleep, what time you woke up in the morning, and how long you napped for in the day. So you could do something like that. But I would also take note of what your child is doing during that nighttime awakening. So I would leave a section for like, okay, you were awake for 45 minutes. What were you doing in that time period when you were awake? Were you sitting there? Were you up? Were you coming into my bed? Were you playing with toys? So what was going on in that time period? And if you're having any behavior challenges either at bedtime or in the middle of the night, collect the ABC data for that. So especially even if it's not what you would consider like a behavior of concern or like something that we would normally classify as a behavior, staying awake in the middle of the night and playing with your toys, if it's disrupting everybody's quality of life and quality of sleep, would be something that we could collect data on. So can I figure out what's happening before? Probably not, because you're sleeping, but at least describing what the behavior looks like and talking about, maybe most importantly, what came after. So what am I doing? How am I reacting to the fact that you're up flipping the light on and off in the middle of the night? Am I quietly walking you back to your bed and trying to get you to self-soothe back to sleep? Am I trying to distract you? Am I turning the TV on? Am I putting you in my bed? Because all of these things can potentially be maintaining factors when you have somebody who's staying awake all night. So trying to get a picture of what it looks like when this is occurring and then how often it's occurring. So sometimes you'll notice a pattern. Sometimes you'll notice that like Friday, Saturday, Sunday, you're having overnight awakenings and throughout the week you're not. So on what frequency is this happening? Is this happening once a week? Is this happening every single day? Is this happening only for a couple days a month, but it's very severe? And that can all give us a little bit of information about what's going on. So before you try to put anything in place, it doesn't have to be a long time. It can be 3 days, it can be a week, just collecting some of that data so you know what your baseline is before you move forward. So the first step, kind of like a preventative step, to putting in place any type of interventions for sleep is going to be to look at the routine in the environment. So anybody who talks to you about sleep is going to talk to you about the importance of establishing a consistent sleep schedule and sleep hygiene practices. So the more, some just basic stuff for sleep hygiene is like, you want it to be kind of a boring, dark environment where there's not a whole lot of distracting stuff going on, there's no noise, there's no anything that could potentially be disrupting your child. I think probably all of you do that already, but the one thing that you might not take into consideration is what toys are sitting around in the bedroom, because if I wake up in the middle of the night and I have nothing to do and I'm really bored, it's more likely that I'll go back to sleep, not me, because I have insomnia, I'll just stay awake the whole night. But if there's something really fun to do, and it's right in my direct line of sight, something that I love, and I can get up and I can play with that, then that's an immediate motivator to get up and out of bed, and then you've kind of already lost the battle. So just taking a look around the bedroom and saying, is there anything here that could be significantly disruptive? Not disruptive in like disruptive to them, but disruptive to you in the middle of the night. So how can I put this in a bin and put it somewhere that's not accessible? Because toys are not for 3 a.m., toys are for daytime. So that's an easy first step that you can take. And then just creating structure. So we don't have necessarily too many issues usually with a structured bedtime routine for kids with PWS because they really, really love routine and they usually love to go to bed. But if you are struggling with any bedtime resistance or with any behavior challenges around bedtimes, then you can make a schedule. I've noticed that it's usually not the routine of actually getting into the bed, it's all the things that come before that, so brushing our teeth in a timely fashion, taking a shower, etc. So you could put a visual schedule in place, or you can give some cues for sleep routines.
Would you, for children who like to go to bed with like a preferred comfort item, would you also seek to remove those?
So the question was for children who prefer to go to bed with a comfort item, does that need to be removed? Unless it's something that unless it's a doll that they're waking up and playing with for 3 hours, I wouldn't worry about it. If it's like a self-soothing item, that's something we definitely want them to have, because hopefully that can help them eventually learn to self-soothe back to sleep. But that's a great question. So when we're talking about creating structure around bedtime and overnight, something else that you can do is give some cues for sleep routines. So sometimes it's difficult for kids, especially if you have like blackout curtains, They wake up at 3 o'clock in the morning and their brain is telling them that it's morning, and they can't see whether or not it's light outside, so it's a perfectly good time to go and walk to mom and dad's bed and ask them if it's time to wake up yet. So one simple thing that you can do is to just signal times for being awake and times for being asleep. Now this is not a magic wand, so it's not going to work all by itself, although it has for some of the kids that I've worked with. But they have this little like light thing, I don't know what it's called, but it turns from red to green and you can make it all kinds of fun colors. So if you think that not being able to understand what's nighttime and what's daytime is part of your child's problem, I would put that light in there and I would make it red or whatever color you like overnight, and then green as soon as it's time to wake up in the morning. This works really well for some kids. However, I did have one child who got obsessed with it and would sit there and stare at it until it turned green. Yeah. So keep in mind that sometimes things that we try don't go according to plan, and if that happens, you may throw the light out the window and tell me that I was wrong, and I will accept that. And so then something else you can do is just promote predictability as much as possible. So that's something that's recommended a lot for kids with autism who struggle with the whole routine of actually getting to sleep. But that's also helpful for nighttime awakenings. So if you are very consistent, whichever of the set of strategies you decide to work with, if you can remain as consistent with that as possible and as predictable with that as possible, that can help not only to help you be more effective, but also to reduce anxiety. So we know for people with PWS, anytime we change something, they do not like it. So if you're gonna make a change, don't make 10 changes, make one change and just stick with it. So being as consistent as you possibly can. So for example, if you decided on a set of strategies for overnight, I would try to stick with those set of strategies because sleep doesn't change quickly. So this is not something that's gonna change in 3 days. It takes a long time to develop a new habit, especially when your habit is as fun as waking up at 4 o'clock in the morning. So you need to give it a good 2 months before you make a decision about whether or not you need to change up your strategy. So giving that time and consistency. So a couple of the strategies that we can think about are first, just gradually reducing your presence. So if you have a child who's struggling to get to sleep on their own, one of the things that you do is you go in, you help them to self-soothe, you read a book, you do whatever, you help them learn how to wind down, and then you slowly reduce your presence until they can do that on their own. So we can do something very similar overnight. So if what you're doing now, because you're trying to save the sanity of your household, is going and taking your child and bringing them into your bed, and then they're either falling back asleep or messing with your phone or doing whatever it is. So we would want to try to fade out your presence, because ideally what we want them to learn to do, I am not a doctor, so I cannot fix the fact that they wake up at 4 o'clock in the morning. All I can do is try to teach them strategies to self-soothe themselves back to sleep and to reduce the impact that it has on your family's well-being. So you could do something like taking them back to their room and you sit with them until they self-soothe back to sleep, and then you shorten the duration of time that you spend in there. So the goal is always independence, but we need to create independence slowly, not necessarily quickly, especially if it's for something like sleep. So if you're spending 30 minutes in there, then you back it off to 27 minutes, and then you slowly fade it out until you're just going in, soothing them, and fading back out. And then eventually what we would like to do is to teach them what we want them to do to self-soothe back to sleep. So that could be like I've had kids use like a kid's meditation. So I would recommend that you go in there, you do it with them in the beginning, and then the goal is that they get up and they do it on their own. So you might have to go and prompt them and fade yourself out and do that really slowly. But there's this it's a ridiculously expensive thing, but sometimes it's really effective. It's called a Zenimal. It's this cute little turtle, and he's got a bunch of little meditations, and one of them is a sleep meditation. So if we're trying to teach kids something that they can do a little bit more independently without needing us there, that's a good option. So we can teach them to use the sleep meditation, see if that's enough to soothe themselves back to sleep, and then set some rules. So set some rules that will help them to understand why these changes are occurring and the fact that the changes you're not going back on them. So if the challenge that you're having now is that your child is getting up and coming into your bed, I would just start off by saying okay, well the new rule is that if you wake up in the middle of the night, I have to walk you back to your own bed. So make it a rule, make it very clear, make there no surprises, and then stick with it as best you can. So generally speaking, something, I'll give a couple of case examples at the end. But something else that I recommend is having some, I say this a million times, but anytime you're trying to change a behavior, you're gonna have to back it up with a reinforcer, especially if it's a behavior that's as challenging as trying to get someone to not wake you up in the middle of the night. So for example, you could reinforce some kind of incompatible behavior. So you could say, okay, listen, remember we have the red light, green light, so as long as you stay in bed, when that light is red, you can come out as soon as it turns green, but you can earn a dance party in the morning if you manage to stay in bed all night. So that's something that you can do. I have some kids who just really seem to have a 1 hour wake period overnight that are a little bit older that probably have been in this habit since they were very young. So something that sometimes we do for these kids is just say like, you know what, you can be awake, and as long as you pick one of these couple of strategies and you stay in your room, then that's okay, you can earn your reinforcer. So I cannot force you to go back to sleep. So if this is your pattern right now and I'm doing my best to get you to go back to sleep and I can't, then okay, pick a solitary and safe activity and stay in your room so that I know that you're okay and you can earn your reinforcer contingent on that. But of course, especially with younger kids that aren't necessarily as deeply in the habit of waking up overnight as some of the older kids are, I would definitely try some type of activity that's going to self-soothe them as quickly as you can, and then hopefully we'll be able to change those habits for the future. And then also, like, I know a lot of times it's easier for you to let them come in your bed and sleep with you because it's like, oh, please just get in the bed and go back to sleep. I will pay you any amount of money to just get in the bed and go back to sleep. But sleeping with mom and dad is way more fun than sleeping in your own bed. So if it's like, it's only going to become a bigger and bigger problem as they get older and older. And it's much harder, like especially for people with PWS who are so rigid and so schedule oriented. When they're older, if you try to rip that Band-Aid off, it's going to be much more stressful than if you set the boundary when they're much smaller and you say, okay, if you wake up in the middle of the night, I have to take you back to your bed. So you're minimizing that reinforcement as much as you possibly can by having them go back to their bed and reinforcing some type of self-soothing activity. So after you've collected your baseline data, you want to be able to analyze whether or not your interventions are working. Because if they're not working, maybe we're not doing the right thing and we got to change it up to something else. So try to just collect a little data before and after, because especially whenever you put an intervention in place for sleep, it's going to require you to not sleep so well for a little while. And so sometimes you feel like it's getting worse when it's actually getting better. So if nighttime awakenings is your struggle, just collect some data on what time your child woke up and what time they fell back asleep. And that can be as simple as sending yourself a text message when they wake up and just saying, woke up. And then when they go back to sleep and you're like stumbling back to bed, went back to sleep. And then you have some duration data. So then you can look at it and you can say, all right, well, when we started this, they were awake for an hour. And now they're like still awake, but they're only awake for 45 minutes. So we're heading in the right direction. Don't give up. Keep trying. And eventually, hopefully, we get to 0 minutes. So that data collection can help your sleep-addled brain to have a little bit more objectivity around whether or not we're having an impact. And then you can analyze your data and you can make database decisions. So if you see that it's getting worse or you see that you're not having any progress, you can change things up and you can try something else. All right, so I have a couple of case studies for you of different types of interventions that I've used for kids previously. So the first one is I had a child who was having a lot of trouble not falling asleep, but trouble with just the whole routine that was associated with going to bed. So as soon as it was time to go upstairs and get dressed and take a shower and everything, then we were having some behavior challenges and resistance. So what I did in that place is I set up a schedule of basically a task analysis of what we have to do from point A to point B and all the steps in between. And then I was giving some points associated with that. And of course, those points were ending up in he was able to earn a little bit of iPad time right before he went to bed. So he was earning his points throughout the night, and then he could trade those in right before he went to bed. And basically, we were using differential reinforcement. So I was minimizing any type of reinforcement as much as I can for the resistance to all the bedtime activities, which was mostly that he was like, I'm not going. I got a helicopter. I am going to play with this, and you can just go away. So minimizing the reinforcement as much as I could for delaying going to do all these activities, and then reinforcing him for doing them well. So whatever steps you do correctly and in a timely fashion, we're getting points for that. And then the reinforcer is delivered at bedtime. We go to bed, the end. For the second case, I had a child who was waking up. It was a younger kid. He was 3, and he was waking up consistently throughout the night. He was going into mom and dad's bed, and he was also the light flicker oner and offer. So he was going into mom and dad's room and going with the light. Nobody was sleeping. So what we did with that in that case is that we got him that red light, green light thing, and that actually worked really well for him. So they did have blackout curtains on his room. There was no way to tell. So that was a good signal for him that it wasn't time to get out of bed yet. And then he was earning a reinforcer in the morning. It wasn't a big thing. It was like 15 minutes of playtime with dad or something like that, contingent in staying in his room all night. And then anytime that mom had to get up and bring him back to the room, she was trying to shorten the duration of time that she was spending with him. So she had been spending quite a lot of time because he was either in their room and she was trying to keep him quiet because they had another child, and you don't want your other child to get woken up. So she was taking him, not saying anything, taking him quietly back to his room, putting him in the bed, and then kind of sitting there quietly so that she was there, he felt safe, he didn't feel anxious, letting him fall back asleep, and then she was shortening the amount of time that she spent in there. And he got to the point where we don't really know if he was sleeping over through the whole night because she didn't have a camera in there, but he wasn't coming to her bed and he wasn't going out of his room. So it's possible that he was still awake at some point in the night, but he was seeing the red light being signaled, and he knew he wasn't going to get to go into mom and dad's bed, so he was staying in his bed and at least staying in his bed throughout the night. And then for the third case, I had a client. It was a 6-year-old girl. I'm pretty sure she was 6. I can't remember if she was 6 or 7. And she was having the same issue where she was getting up and going to mom and dad's bed. But for her, it's not even like she was getting up and doing stuff. So she wasn't getting up and playing. She wasn't getting up and wandering around. She was just going up and going to mom and dad's bed and falling right back asleep. So we assumed that maybe it was an issue with the ability to self-soothe, because she could fall back asleep perfectly fine. She just was having a hard time falling back asleep in her own bed. So she was the one that we got the Zenimal for, and we were teaching her to go ahead and if she woke up, the first thing she was going to try before mom did it with her for a couple nights first, but we told her first, just try your sleep meditation, and if you can't sleep still, then okay, go wake up mom and she'll try to help you. And that was all she needed. She needed a very clear instruction on what she was supposed to do in the middle of the night to get herself back to sleep. And mom had done some other kinds of meditation with her, like kids meditations with her before, so she was really familiar with it. And that was something that really worked well, and we didn't even need a reinforcer. She just needed to be told what she needed to do. So that wraps up the speed version of the how to deal with sleep problems. So we'll do questions. Yes, no, go ahead.
It kind of lies into toilet training. With all the case studies that you did wet diapers or constipation, which is typical of children with PWS, did that play a role in that kind of thing?
Not for these people, not for these clients, but I have had clients where that was the case, where they were wetting their diaper or they were like mid-toilet training and sort of figuring out how to go to the bathroom, so they were waking up, going to the bathroom, and then they were just awake afterwards. That would fall under the, sometimes there are just aversive sensations that we can't get away, we can't remove. Yeah. So in that case, your goal would be, depending on your child's age, to move towards toilet training, and you would probably have to do something like, okay, if you have to wake up and pee, then we go back, we do the meditation, we get back to sleep, and increase that independence to the degree which you can. But yeah, it's hard, especially when you're not quite toilet trained or you're mid-toilet training. I've had kids who were sleeping perfectly fine, and then they start to wake up to go to the bathroom overnight when they start to toilet train, so. The question was, how do you spell the name on the turtle? It's Zenimals, like Zen and animals smushed together with no A. It's really cute, but it's like $70. It's a piece of plastic with recordings on it. I don't know why I didn't think of that. I could have just gone into business making plastic with recordings on it, but it does work, and it is very kid-friendly, and they like it because it's a turtle, so. Any quick questions before we switch over to toileting? We'll hang out at the end, so if you have any more questions, you can ask. All right, perfect. So I'll pass it over to Dr. Griffith.
All right, thank you. So Dr. Bedard had some nice things to say about me at the very beginning, but I will have to say that, so I've been in the field of working with children with either autism or other developmental disabilities for quite some time, but my experience with PWS is a little bit limited. I have worked mainly with adults living in residential settings, but that had been quite some time before I met Dr. Bedard, and so I definitely would say that I actually turned to her as the expert for PWS for sure. But I will start out, so I have been working with individuals with developmental disabilities for going on over 20 years now. And when I started, I started working out with adults, and then I transitioned to working with children. And a lot of the work that we did, almost every child we worked with initially, we worked on doing some toilet training with. And so I actually started out I was the youngest of 6 kids, so I had no experience with how to do toilet training at all. But I was worked with helping with toilet training with the first kiddo when I was about 18 years old. So I was like 18 years old, toilet training, and I'd been doing it for quite some time. So then by the time I had my own kids, I was like, I've got this, right? And I'm like, I know exactly how to do it. It's gonna be super easy. And then I had my own kids, and it was not super easy. And I think when I was, working to toilet train my daughter, I think like 2 days in, I was like, oh my gosh, this is the most exhausting thing I've ever done. And because it's definitely different to go in as a clinician or a professional working with a family, helping to guide them through the process, than it is to be a family member actually doing the hard work 24 hours a day, day in, day out. So we will kind of keep that in mind as we go through and talk about some of these strategies that it's not always going to be easy. Sleep and toilet training, I think we picked 2 of the hardest things, because it's not just, a behavior that we have to deal with, from time to time. These are things that are every day and that have such an impact on an individual's quality of life and on our quality of life, right? Because if your child's not sleeping, you're not sleeping. If your child's not potty trained, that impacts where you can go, what you can do, all different kinds of things. So it's definitely not going to be something easy, but hopefully we can share some information that'll help you feel more empowered to move forward. All right, so toileting difficulties are common among individuals with PWS. And there's lots of different kinds of difficulties that these individuals might experience. So it might be that they're having accidents, and they're just, not able to either initiate that they need to go, use the restroom, or that they're not able to control that. Also sometimes we see kiddos that are actually scared of the toilet, scared of the bathroom, especially, if you're using those public restrooms with the automatic flushing, sometimes that, that can take anyone by surprise. But if you have, a kiddo who's not expecting that to happen, that can be really scary. So, and sometimes, I've seen that actually kiddos who are not scared of the bathroom become scared of the bathroom after using bathrooms like that. But regardless of what our kiddos' difficulties are, whether it has to do with being able to, hold things for a period of time, or being able to initiate, or actually go into a restroom and use it, we have to remember that toileting is a really, really complicated skill. For most of us, it's something that we don't even really think about. Like, you can kind of rush in, rush out. It's just not something you really think about, all the different pieces. But there's actually a lot of different sub-skills that make up toileting behavior. And that's kind of one of the very first things is, if we can recognize all of those different sub-skills, that can kind of help us to identify where are our child's difficulties. And Dr. Bedard talked a little bit about, kind of understanding the reasons why kiddos are having difficulties. And once we figure out the reasons why, then we can start to look at how do we address that. Is it a skill deficit? Is it a motor skill deficit? Individuals with PWS, we know if they have, low muscle tone, if they have difficulties with fine motor skills, things like that can really impact any point in that process. So just thinking about initiating, so that's recognizing that the individual actually even has to use the restroom, right? And so being able to do that, and then also being able to to make a request or, self-initiate, just getting up and going. Like, there's a lot of different pieces there. Undressing, if someone's, usually whenever we do potty training, I always recommend parents put their kids in like sweatpants or pants with elastic waistbands, things that are easy for them to kind of pull up and down. Putting them in buttons, putting them in overalls that have those little clips. There's certain things that if a child has difficulty with fine motor skills or isn't able to actually undress or redress, that can be really challenging. For individuals with PWS, particularly a consideration is due to their low muscle tone, just being able to sit on the toilet, stabilize, and feel safe doing so, not just that can they do it, but can they actually do it in a way that they're feeling safe and secure. Wiping, flushing, washing hands, all of these are steps kind of in that toilet training process, and knowing where our kids are having difficulties is kind of really important so we know how do we move forward. So as Dr. Bedard had talked about with sleep, toilet training for individuals with PWS is pretty much, we're in the same boat for that. It's very, very preliminary. We actually have a toilet training program I'm going to talk about in just a little bit that we've started to look at for individuals with PWS. Prior to doing that, we went to the literature to try to find out what's been done. What do we know so far about toilet training individuals with PWS? And I will say that we found nothing. Did you find anything after? Okay, yeah, we found literally zero. And we even actually looked, sometimes when we look at research on just various topics, we might find an article that talks more, it's just kind of more general. So they'll talk about, an intervention for individuals with developmental disabilities, and there might be a participant that has PWS included with other types of participants as well. So we even went to some of the just general toileting literature. There's quite a bit out there on autism and just kind of developmental disabilities in general. But so we went to some of those articles to say okay, well maybe there's an individual with PWS that got included in a study, but it's just not popping up as a keyword because it wasn't the focus. And I didn't even find anything related for that. So as far as I'm aware, there's no research at all looking at how do we potty train individuals with Prader-Willi syndrome who have, a lot of physical, disabilities that are impacting or medical complications that are going to impact that potty training. So the research is very, very preliminary. Most of the research that we ended up kind of looking to then was research for individuals with autism, related developmental disabilities, and or just typically developing young children. We looked at those. And just from my clinical experience as well, it's not uncommon that a child with autism or developmental disability, or even typically developing kids at times, will have difficulties with fine motor skills. Like I said, I always recommend parents put your kids in elastic waistband pants because they're easy to go up and down, because either little children or children with developmental disabilities, regardless, even if they're a little bit older, sometimes those things like buckles, like belts and buttons and all those things can be challenging for any of those kids. Say no. Say no, not going to accept that. So although the literature is not tailored towards individuals with PWS, there's still some things that we can kind of draw from it and figure out okay, what do we know works for other populations, and then how do we then figure out what pieces are going to be relevant for individuals with PWS and which ones maybe not so much. And so we started just to look at similarities. And so like I said, just right off the bat, we know, fine motor can be a difficulty, but things like low muscle tone, that's going to be something that probably is going to be a little bit more unique to individuals with PWS. But I'm just going to talk a little bit now just about some of the things that would be common that we would be really interested in looking at regardless of who we're potty training. It doesn't even matter if it's an individual with disability or not. What are some of the things that we want to do so that we can figure out how do we tailor something that's going to be individualized for the kiddo that we're working with, I say kiddo, but really we've worked with potty training adults as well. So for the individual that we're working with, to try to make something that's going to work for them. So as I mentioned at the beginning, potty training or toileting is a really complex skill. There's a ton of different pieces to it. There's lots of different components. So that initial assessment is really important. Trying to figure out what steps in a toilet training sequence can my child do or my individual do, and which ones can they not do. And looking at not only looking at essential, so I talked here about focusing on essential steps, but also thinking about like their ability to do it, like so skill, but then also kind of willingness to do it, right? Because sometimes people can do things, but they're not wanting to do things, versus sometimes they really truly can't. So looking at both of those and sometimes it's hard to tease them apart, but if we could try to figure out at least what can they do, what can't they do, what are they willing to do and not, it gives us a good baseline and it gives us an idea of where to start. So one of the things, one thing else, well, just to kind of mention, so toileting is something, obviously there's going to be a lot of cultural differences for individuals related to toileting. And so one of the things that we do recommend is really just thinking about what are the essential steps that the individual that we're working with, what do they need to have in order to be successful, focusing on those first, and then from there working to focus on the cultural pieces. And the reason that we do that is just to make sure that they can be as independent as possible, and then kind of going from there. Because we think it's really important that we want to consider family and cultural preferences anytime we're looking at having skill building programs and focusing on that. But we also want to make sure that we want to start with what's easy first, right? So what are those essential skills? What's easy? What can we do to make sure that they have independence? And then we can shape from there. But so as Dr. Bedard talked about, we're behavior analysts and we like data, but we like it because it's really useful. It can tell us about, like I said, what an individual can do, and then it can help us to see changes over time. Things like sleep and toileting, those are like kind of emotional skills to teach, right? Because if we're tired, we're exhausted, it's hard. If people are having accidents and we're trying to rush out the door and then we've got to change people, or we can't go somewhere because of toileting behavior and stuff like that. There's just a lot of emotion tied to it and a lot of like energy, right? A lot of our energy goes towards those types of behaviors. So sometimes it can be hard to see when there's little progress. And things like sleep and toileting, those can be things that sometimes they might change quickly, but a lot of times they might not change as quickly as we would like. So being able to collect data will help us to know where the individual is, what we need to focus on for training-wise to help them to be successful. But then also, are we making progress? Are we making the progress we'd like to see? So once we've figured out what skills does our individual need to have, how do we move forward? Three kind of important things, or we want to look at setting up the environment. And there's three important reasons that we want to do that. One is we want to minimize messes, right? So anytime you're looking at doing potty training, toilet training, thinking about, where can we do this in a way that's going to be easy. So just as an example, I was talking about, when I was potty training my own kids, we had a main floor bathroom. We had hardwood floors, tile floor in the bathroom. So we just made that area, like our dining room, bathroom, living room area, we blocked it off, and that's where we stayed for like a week. We didn't go anywhere because that was an area that we could have our kiddos in underwear. We didn't have to worry about accidents on the carpet in the stairs or in the bedroom. So that's where we were. So we were able to minimize messes. Limiting distractions, if you're potty training in one of your bathrooms and there's a bathtub there with all the bathtub toys, that can be really, really distracting. If we're looking at, trying to keep kiddos focused and interested, sometimes we, maybe want to use an iPad or something like that, but we always want to think about, is that going to be, is that going to be helpful for us or is that going to cause distractions? And then obviously the biggest thing is we want to ensure safety. So we want to make sure, if you have a kiddo who has difficulty being stable on the toilet, we want to make sure we have appropriate like bars or railings, that we're there watching them. Anytime that we're around, places with water, toilets, bathtubs, sinks, we want to make sure that we're there and that we're safe and that we're able to set them up for success. So some of the required materials, we want to think about reinforcers. So anytime we're looking at teaching something that's going to be hard for one of our kids, we want to think about, what are some rewards that we can provide for their attempts and their initiations and their successes. So identifying things that we can be used as reinforcers. And depending on our kids, they might be something like a couple minutes on the iPad. It can be things like Skittles, gummy bears. I know for kids with PWS, we want to be thinking, really carefully about food. But we can be thinking of like if an individual has certain allotments of things that they can have, how can we maybe tie those in to times that we're doing our potty training. And then also any needed medical equipment. And this is Dr. Bedard had talked a little bit about kind of getting that medical clearance first. So making sure that our kids are ready for potty training, but then making sure that we have the tools that we need. So if we know a kiddo has difficulty kind of stabilizing, make sure that we have, a seat adapter or handrails so that they can feel safe and secure as they're working on potty training. Mm-hmm.
Do you think the older the child gets, the worse and the harder it will be to potty train them?
Yeah, so the question is, if as kids get older, is it harder to do potty training? I would say, I don't want to say it gets worse, but I would say it definitely is going to get a little bit hard. So there's probably kind of like a sweet spot, right? Because you want to make sure that your child's developmentally ready and physically ready to potty train, because if we do it too early, we're not going to be successful, and that's going to be frustrating for you and them, and potentially set up a history with, some challenging behavior there. But we also don't want to wait too long where we've developed routines and habits that are going to be harder to break later. So it's kind of, there's like that little sweet spot of making sure that they're ready, but then hopefully not waiting too long. I don't know, I haven't worked to do potty training with any adults, like older teens or adults with Prader-Willi syndrome, but I have worked with kids, or older kids and adults with autism and other developmental disabilities, and we have done potty training. And I will say, just from my experience, it has been more challenging because, again, we've got that history that we're trying to work through. Have you done potty training with adults? No. So,
Just one more on piggyback off that, or with this
yeah.
He's, for the most part, daytime potty training, he's not good for, something else, but bedtime. Should she get him up in the night to have him go to the bathroom? Because he has those sleep issues, just like we were discussing in the first. So, what do you do? It's not like a normal child, get him up, now go back to bed, and go to sleep most of the time.
So did you?
When I was
So the question is, if you have an individual who's daytime potty trained but not at night, should we be waking them up at night? And sorry, you said he does have sleep issues, or he does not? He has a sleep disorder. Okay.
Is he sleeping fully through the night? He's sleeping. Huh? Till 4 a.m. Okay. Till 4 a.m. So if he has woken up in the middle of the night before and you don't have issues getting him to go back to sleep, I think you would be safe to wake him up to go to the bathroom, because probably he'll go right back to sleep. When we have a really hard time is when kids wake up in the middle of the night and then they're awake for the next 3 hours. In that case, I would probably say work on that first, and then when you have kids consistently and easily going back to sleep, then you can take a step back and go back to the potty training. It's whichever pain you're willing to endure.
Yeah. Yeah. Yeah, and that's what it's, like you said, none of this is going to be easy and be, yeah, exactly. Which one is going to be the one to focus on more? Personally, I probably would focus on the sleep first, because if I'm not well rested, nothing else is going to happen. Yeah. So as you've collected your initial data and you've identified what can your child do, what can they not do, start with the steps that you know that they can do. Prompt them through the rest, and then allow them to independently do what they can do so that you can provide reinforcement for that. And you can get that strong pairing between what they can do independently and that reinforcement. And honestly, even if it's something like, even if you have to start at the very end of that whole chain of behaviors where they say, all done, or they wave their hands and say, all done, even if you're starting there, being able to then provide reinforcement and say, like, great job, you said all done, and, and be able to reinforce that, then you can start to figure out, okay, we've got that down. What's the thing that they're closest to next? And what can we go to next? And then slowly start to shape that behavior from there. So even if it's really, really small. And then slowly you can start to build towards that independence. And like I said, toileting is a super complicated skill. So focus on successful voiding first, them actually using the bathroom, being able to reinforce that. Even if you have to initiate, take them, they go to the bathroom, and then you help them, redress, wash their hands, flush, all that stuff. Focus on that as being your primary goal. Once you have that, then you can start to build on all those other skills. And then, like we said, yeah, toilet training older children can be more complex. We've got that history that we're dealing with, so that's something for us to be thinking about too. And so, as we mentioned, that ongoing data collection can be really helpful and help us to monitor our progress, because sometimes things are going to go fairly quickly, sometimes they're going to be a little bit slow, and so we want to be able to see, and sometimes we'll see setbacks, right? Sometimes our kids will start to make progress, and then all of a sudden, we traveled, we had company, we had, things start to happen, and we'll see things step back. So being able to collect that data can kind of make us recall, like, okay, we were here once before, we were worse once before, we made progress, we've got to step back, but I know we can keep moving forward. So it's really helpful. And it helps you to make data-based decisions as well, knowing when to start adding in new steps and be like, okay, they've had this skill for maybe, this portion of the skill for about a week now, 2 weeks, maybe I can add on an extra little piece now. So it helps us to kind of decide when to move forward. And just remember that every kiddo is going to be different, and being able to, adapt to your kiddo and what their needs are will be important too. And I know we don't have a ton of questions or minutes left for questions, but I was just going to tell you like my favorite potty story ever, because I think it's just the best example of like meeting a child where they're at and then helping them to shape that behavior. So I was working with a kiddo, and I don't even know what type of developmental disability they had, but he was, I want to say like 10 years old maybe when I met him, and he was terrified of the bathroom. He did not want to use it at all. And so as we're working, so we developed this great reinforcement system. We're like, okay, we're going to tell him like, okay, and make this rule. So we're like, if you use the potty, we're going to have this reinforcement. And we shared with him like what it was going to look like. And we were super excited because we're like, oh, he loves whatever character it was, and this is going to be great. And we had no opportunity for him to even get access to the reinforcer because we had nothing to reinforce. And so we were like, okay, we've had to reinforce something. So as Mom said, he actually pees like every night in the tub. And so we were like, okay, he pees in the tub, let's start there. So I had Mom literally catch his pee in a red Solo cup, and so she could say like, woohoo, you peed in the cup, so we could reinforce it. So every night she'd like woohoo, you peed in the cup. And so eventually he actually started initiating. He'd be downstairs playing and say like, I have to pee, and he'd run upstairs, get in the bathtub, and pee in the cup. And so we were like, okay. His mom was actually thrilled. She was like, we can stop here. And I'm like, we can't stop here. So we slowly got the cup out of the bathtub. We got the cup over beside the toilet, and then we got the cup on the toilet. And this was a kiddo that was he wouldn't go near the toilet, but he was consistently peeing in the cup on the toilet. So then we lifted up the lid, and I don't know what his mom did, but it was like suspended or something. So it wasn't like in, but it was kind of up. And so we got him so that he's peeing in the cup. Then we got the cup in the toilet, and then we just slowly started cutting down the cup. And it took a really long time, but the last I had heard, he was using public bathrooms, even the kind with the automatic flushers. He was using the restroom at friends' houses, and he was initiating. So we were super, super excited, but we had to figure out like, where is he? How do we meet him where he is? And how do we go super slow? Like, it took a long time. It was a long process. But it's, so anyways, that's my favorite potty story, which I don't know if anyone should have a favorite potty story, but. but
Reiterate that because I think, one, it does take time. It took us a long time to put him on lots of slow, long steps. But I think what I love about it is that they have the ability to learn. And even if it's to run upstairs and do it in a cup, in the tub, that is like that moment as a parent, you're like, they get it. They may not get it there, and they will get it there, but they get what we're doing. So
And
to have that expectation that they can.
yeah, and I think that's the piece too, like not only can they, but like I said, Mom was thrilled, like she was like, let's not mess with the cup. Like she's like, she's like, this is the best things have ever been, like let's just keep it here. And so, knowing that like, as you make progress, recognizing like, yeah, we've made progress, but we can still get here. It might take time, it might take us really weird steps to get there, like peeing in a cup, but we can get there. And so just remember that every kiddo is different, and kind of figuring out where they are and helping them to go from there. So we've only got a couple more minutes.
Can I just give a shout out to occupational therapists if you have one? Because they're really good at figuring out different ways to wipe, different ways to do all the steps.
Yeah, and actually, just prior to this, earlier today, actually, we were just chatting about. So we didn't really get into our discussion on our pilot study looking at. We have adapted a toilet training protocol for individuals with autism, tried to tailor it towards the needs of individuals with PWS. We're currently working on a pilot study for that, and it seems like it's probably been successful for some of our participants, but maybe not everybody. And as we've kind of started to look at, like, well, who's it not really working for, some of the things that we've noticed are maybe individuals who do have lower muscle tone, who are maybe a little bit younger and maybe weren't quite ready yet. So really being able to work with physical therapists, with their doctors, being able to make sure that they really are ready. And it might not coincide with like the typical age for potty training, right? And so just being able to make sure that we're figuring out what individuals need where they are.
How many minutes do we have? We have 3 minutes for questions, and then we'll stand in the hallway.
Yeah.
I don't have a question, but I just want to thank you. I went through Dr. Bedard's program.
Yeah, Christina did our original Smart Start study.
Not a data.
Yeah.
Not a data.
Yeah. Oh wait, I made a QR code, guys.
Yeah.
So I'll just share while she's getting it.
Yeah.
She had the ABA training for the parent, well, for her students, for the parent. And I feel like the reinforcer didn't even have to be a thing. It was able, we literally, if you could have shut the lights down and thrown a disco party in our bathroom, the entire family came in. We all like sang, the party, literally all my entire family was in the bathroom, jumping, singing, clapping, and she loved it so much we did it over and still do. It's not the whole family anymore, it's just me. But I'm telling you, she's there. She's there. With this, it takes the work. But it has worked, and now we're just on the OT visual chart, which kind of coincides with the white baby. But other than that, it's like amazing. So listen.
Yeah, I will. So my daughter's actually here today, and so I'm like, I don't want to give away all my secrets, but I feel like maybe she's old enough that I can give away a secret. Is that one thing that's really helpful is like if you have something that's going to be really cool that's happening, or that you're going to be giving your child, or something like that, that just is happening anyways, you can always tie it to stuff. So like my son actually thinks we went to Disney World years ago because he met his reading goal, and we were going to Disney World anyways, but he's 18, and he actually just mentioned this like a couple weeks ago, and he's like, that was really weird that you took me to Disney just because I met that goal. And we're like, yeah. So reinforcers don't have to be, they can be things, they don't have to be things, and they can be things that were probably going to happen anyways, but you can tie them together and be like, woohoo, you did this, so therefore. Yeah.
So that's a difficult question. That's probably a question I would ask the GI doctor, who is here somewhere, because she had a session that I wanted to go to. But that would be something that I would ask a medical provider, or maybe a like physical therapist, because it seems to be one of two problems. I have kids who can't initiate because they can't figure out the physical sensations of pushing, and I have other kids that it seems like they. You got to put it on a schedule. So when you start, put it on a schedule. So like, for example, oh, sorry, we're out of time. I'll tell you in the hallway. Real quick, I have 2 QR codes up here. One links you to our research opportunities. If you have any interest, we're actually replicating the study that Christina participated in. So we have that up here. And then the other one is just to my website, because I'm going to be posting all of our handouts, all of our everything. So if you want that, go there. There's a bunch of free stuff on there. Thank you.